welcome to the deep dive. Today we're tackling something quite rare, but incredibly serious. Boerhaave syndrome.
That's right. It's definitely one of those conditions that, while uncommon, is crucial for medical professionals to recognize quickly.
Exactly. So we've looked at the revision notes, pulled out the key stuff. Our mission today, make Boerhaave syndrome clear, concise, and hopefully memorable.
Let's do it. So Boerhaave syndrome, put simply, it's a tear, but a full thickness one, right through the wall of the esophagus.
A complete rupture. And what usually causes something that, well, dramatic.
The classic cause is really forceful vomiting or retching. That sudden, intense pressure is what does it.
Okay, so it's about pressure. Can you elaborate on that mechanism a bit?
Sure. Imagine during really violent vomiting, the pressure inside the esophagus just skyrockets.
Okay.
Normally, the muscle at the top relaxes to let things out, but if that doesn't happen properly while the stomach is forcefully contracting, the pressure builds up incredibly quickly.
Ah, I see.
And if there's a weak spot or just overwhelming force, the wall can literally burst.
Wow. So are there things that make the esophagus, weaker or more susceptible to contributing factors?
Definitely. Heavy alcohol use is a big one, often linked with episodes of severe vomiting.
Right.
Overeating, binge eating can also lead to it. And sometimes, though less commonly, certain medical procedures involving the esophagus can unfortunately be a trigger.
Okay, that makes sense. So thinking about who's at risk, are there specific groups or conditions?
Yeah, there are key risk factors. Actually, there's a handy way to remember them. Think a heap of risks.
A heap. Okay, I'm listening.
A is for alcohol abuse. H for hiatal hernia that can sometimes weaken the lower esophagus. E for eating disorders, particularly those involving purging. Again, for procedures involving the esophagus like endoscopy, though that's rarer.
Right.
And P for previousoesophageal surgery. Anything that might compromise the wall's integrity, you see.
A heap, alcohol, hiatal hernia, eating disorders, procedures, previous surgery.
Got it. That's really helpful. So pathologically, what's happening when it ruptures?
Well, the tear itself typically happens in a specific place, usually the lower third of the esophagus on the left side towards the back.
Right.
That seems to be the weakest point structurally.
Left-posterolateral, distal esophagus.
Exactly. And when it tears, everything inside the esophagus, air, saliva, food particles, stomach acid leaks out into the chest cavity, specifically the mediastinum.
Into the space around the heart and lungs. That sounds immediately dangerous.
It is. That leakage causes rapid severe inflammation and infection mediastinitis. It's a critical situation.
Which obviously explains why the symptoms are so severe. But severe chest pain can mean many things. How do you differentiate Boerhaave's?
That's crucial. The differential diagnosis is broad. You absolutely have to rule out things like a heart attack, an MI, or a pulmonary embolism, a PE.
Okay.
Also, bleeding esophageal varices, or even a Mallory-Weiss tear, which is a more superficial tear, also from vomiting, but not full thickness. So what distinguishes Boerhaave's pain?
It's often the suddenness and the intensity. Patients might describe it as a ripping or tearing feeling, incredibly severe, often radiating to the back or shoulders. It's usually unrelenting.
Right. And how common is this? You said it's rare.
Very rare. We don't have precise UK prevalence figures, but it's certainly not an everyday diagnosis. It can happen at any age, though.
Okay. So let's talk clinical features. What are the key signs and symptoms we should look for? We mentioned the pain.
Yes, that sudden, severe tearing chest pain is number one. Then, a really characteristic sign, if present, is subcutaneous emphysema.
Air under the skin.
Exactly. Air leaks from the ruptured esophagus, travels up into the neck and chest wall tissues. You might feel a crackling sensation under the skin called crepitus.
Okay. What else?
Signs of systemic illness quickly develop. So fever, rapid heart rate, tachycardia, low blood pressure, sweating, basically signs of sepsis and mediastinitis setting in.
So maybe we can think of the 3 S's here. Sudden severe pain, subcutaneous emphysema, and signs of sepsis mediastinitis.
That's a great way to frame it. The 3 S's captures the key features well.
Good. So if you suspect it based on these features, how do you confirm the diagnosis? What investigations are needed?
You'd start typically with a chest x-ray. It might show air in the mediastinum, pneumomediastinum, or maybe a pleural effusion or pneumothorax. But it can be normal initially.
So not always definitive.
No, not always. The gold standard really is a CT scan of the chest, usually with oral contrast. That can pinpoint the leak, show the extent of contamination.
Okay, CT scan. Anything else?
An esophagogram using a water-soluble contrast agent like gastrographin can directly show the leak on X-ray as the patient swallows. Sometimes careful esophagoscopy is done, but there's a risk of worsening the tear, so CT is often preferred first.
Right. Makes sense. And once it's confirmed, what's the management?
This is a surgical emergency, no question. The patient needs immediate intervention.
Surgery to repair the tear.
Yes, primary repair of the esophageal rupture is the main goal, often reinforcing it with, say, a muscle flap or other tissue. Plus, thorough washout of the chest cavity is vital.
And presumably, antibiotics are crucial given the contamination.
Absolutely critical. Broad-spectrum IV antibiotics immediately. And supportive care is vital too. IV fluids, nutritional support, pain management. It's intensive care level treatment.
It sounds incredibly challenging.
Well,
What's the prognosis like?
it heavily depends on how quickly it's diagnosed and treated. If surgery happens within, say, 24 hours, the outcomes are much better.
And if there's a delay?
Then, unfortunately, the mortality rate is very high. The longer the delay, the worse the sepsis and mediastinitis become. It can exceed 50% mortality with significant delays.
That really underscores the urgency. What are the main complications to worry about?
Well, mediastinitis and sepsis are the big immediate life threats. Respiratory failure is common too, from the chest contamination and inflammation. And of course, there are potential complications related to the major surgery itself.
So early intervention is everything.
It really is. It dramatically improves the chances of survival and recovery.
Okay, so wrapping this up, Boerhaave syndrome. Rare, life-threatening, full-thickness esophageal rupture, usually from forceful vomiting. Key signs are the 3 S's: sudden pain, subcutaneous emphysema, sepsis signs. Diagnosis via CT. Management is urgent surgery and antibiotics. Prognosis hinges on speed.
That's a perfect summary. Swift recognition is paramount.
Absolutely. And for everyone listening wanting to solidify this or explore more, definitely check out passemsashway.com and freeimpecer.com for great resources.
Good call. They have excellent materials.
So a final thought to leave you with. Given the link to things like alcohol abuse and eating disorders, how could better awareness or screening in those specific patient groups potentially catch risk factors, or maybe even early signs, before such a catastrophic event occurs? Something to ponder. Thanks for joining us on The Deep Dive.